over the next few minutes, we're going to be adding people to our conversation, but this will be a laid back conversation. And maybe I'll just start by just saying why we created practice habits. For those of you who don't know, I was a practice administrator for just over 20 years of Vance Thompson Vision, where I was the CEO. And before that, I worked for a marketing company and still did Vance's marketing. So worked really in ophthalmology for now, well, 26, 27 years. And one of the things that we found, and maybe it's because we're in the Midwest, maybe it's because we're hard to get to, but what started to happen is if we wanted to make change and implement new technologies, if we wanted to find the best practices for team culture, for billing and coding, we had to kind of teach ourselves. Maybe it was because we were the end of the travel line of people's territories, but we just kind of had this mentality that nobody's coming for us. And what that did is it created an environment where we really wanted to take what we've learned and share it with others so they can get smart and learn to implement things faster. What we learned over time is that as we found how to make change, not only could we share how we performed a certain task, we could help teach others how to make change in their programs as well. And so practice habits is really just a way to give back in that same way. It's a place for administrators and some industry support teams to come. And there's a clearinghouse of topics. We're committed to doing it every week, which means 40 weeks a year. Because there tends to be holidays or other things that kind of get in the way. But we range in topics from how do we answer our phones to how do we build team culture by way of compensation to what we're going to talk about today, which is how do we take a complicated category, which is interventional glaucoma. Sounds simple, but how do we create a pathway where practices really have confidence about doing the right thing for their patients, not relying solely on drops? And so, those of you who are in attendance today, thanks for coming. I want to introduce you to a couple of my friends who are helping us with this discussion. Tracy Brackett is the head of U.S. Market Access for Alcon, and Nadia Early is a reimbursement liaison for Glaukos. And I've gotten to know these two professionals over the last now probably 10 months as we prepared for a master class where we were doing a similar presentation, although in much greater depth. And I'm just here to tell you, if you're starting to perform a new procedure, and you're not sure how to get it through the process, these are the types of people you want on your side. They're going to help do the hard work of talking to the MACs, talking to the different, subgroups of payers to try to make things common, but also challenging your teams at the practice level. That just because you get a denial doesn't mean you stop. Here's how you rework that claim. Insurance companies, they're playing a lot of games these days. And they know that the majority of times when they generate a denial, that claim is going to no longer be worked because some frontline team member doesn't necessarily know how to do that. It's the unfortunate reality of the healthcare world today. And I'm just proud as punch that we have folks like this working with us at the practice level to make things a little bit more clear and to help us kind of create the right expectations for us and our team. So Nadia, Tracy, thank you for joining us.
Thank you for having us.
Yeah,
Happy to be
thanks for
here.
having us.
Tracy, you're at AGS right now, about to kick off a big weekend of talks. I'm sure very much in line with what we're talking about today. Nadia, you just finished a big national sales meeting for Glaukos, and you've got, I know, a full plate of things you're intending to accomplish over the next, 12 months. So I want to just first get started by asking you a little bit of what's your primary responsibility day to day? Where do you see kind of your work within the whole of Alcon? And I'll start with you, Tracy, then we'll ask
Sure,
you the same thing, Nadia. Both, contained to, interventional glaucoma and access.
sure. Well, first of all, thanks for having us, Matt. I too have enjoyed getting to know you and Nadia better. And my role as head of US market access is primarily as it relates to glaucoma is thinking about proactively how to create access for patients. So, how I do that is partnering with specialty societies as well as our trade associations to impact health policy with CMS and the MACs. That's number one. I also get the opportunity to lead a field reimbursement team that's probably similar to Nadia's role as a reimbursement liaison that works with customers across the country. And what we do is we really focus on education, troubleshooting underpaid and denied claims, as well as reimbursement business reviews. The education is really important. I think everybody on this call will agree with the turnover in staff in so many practices. Sometimes it really helps to just provide that baseline education for billing and coding for interventional glaucoma procedures. So, like I said, my primary role is to lead a best in class field reimbursement expert team as well as impact health policy.
Nadia, how about you?
Yeah, thanks, Matt. And thank you also for having us here. Really happy to be here and have this conversation. I think it's really important, especially in the interventional glaucoma space. So I am the reimbursement liaison for Glaukos. I support the glaucoma franchise. Similar to Tracy's field team of reimbursement specialists, I help practices, surgery centers, understand the basics of billing for our products, especially, as these products come to market, helping navigate the barriers that come with that, with certain payers, when policies come out, educating on what those policies are so that these patients can get access for treatment. And then really following, the patient through the whole journey. So from when they're first identified to when that claim's adjudicated. And then if there's any issues on the back end, with payment, our team is there to support with that as well. I'm based in Southern California, so currently I'm covering California, Washington, Oregon. But I think really what our team has been able to help with as well is for what's going on the East Coast, we can kind of share that knowledge and intel with certain payers to help practices overcome these barriers to get access for patients.
Well, and I want to talk about first, before we get too deep, is I want to talk about why it's important now. I mean, we have this, and we've talked about it in a few of our previous sessions. I think glaucoma has carried this inflection point. There's a sense of converging forces where just a decade and a half ago, glaucoma care meant either drops or some big tough procedures that carried about a 50%, my words, efficacy rate. Tubes, trabs, shunts, big, procedures. And then there was some innovation in the middle with minimally invasive glaucoma surgeries. Nadia, your company helped kind of lead the charge there, but there's been several now. And it's even, I would even dare say, a crowded space where there's a lot of different technologies that exist here, but they almost all were done in conjunction, not all of them, but almost all in conjunction with cataract surgery. And since then, there's been some unbundling. So now things can be done in a form that's called standalone, meaning you can do it alone without the implant part, the cataract surgery part, which when you talk to administrators like me, I think, oh, wow, you mean I can go back to all of my happy cataract patients who are on drops and tell them we have something new to offer them that can make their life better, which we've never had before. Repeat patients aren't something that's been in our nomenclature. Cut to other things that are a little bit more first line, like lasers or procedural pharmaceuticals, other items that are kind of that first line that can be done before even an implantation of like a MIGS kind of device. That alongside the frustration of knowing that patients don't take their drops, knowing that a lot of them don't even fill them in the first place. Many of them have adverse events, dry eye or otherwise. And because they're not taking their drops, they're also more likely to be lost to follow up. Whereas if they have a procedure, we know they stick with their provider longer. So all these things kind of go into the mix. But you both see something at the national level that's also going into the mix, which is the position of payers, because they're holding on to dollars more tightly than normal. Give us a sense of what it's like out there amongst kind of the payer culture. Tracy, I'll start with you with that.
Sure. I think, and we're all smiling because we feel it, we see it every day. Right now, Medicare Advantage covers more than 50% of Medicare beneficiaries in the country. So in 2024, Medicare Advantage made up 54% of Medicare beneficiaries. And when I talk to customers, I let them know what this means is that commercial payers really do not have to follow Medicare unless it's considered medically necessary on the MAC, right? So if a procedure is not medically necessary, those Medicare Advantage providers will don't have to cover if they don't have enough evidence. And they lean towards not covering if they don't have to. So what it creates on our end is that work to provide the evidence to show why they should, right? We're very fortunate, both Nadia's company and mine, for the MIGS code that we share, 66991, is medically necessary on all of the MACs. So for hydrous and cataract surgery, that's good. However, there is a perception by a lot of customers that MIGS just aren't covered across the board. So they might shy away from it, or they may not understand what their payer mix is. So that's on the MIGS side, that's what we see. When it comes to SLT, we are seeing excellent coverage across the board. From time to time, we'll see a small regional payer say, oh, there's a little bit of utilization uptick. I don't know if I want to cover this, and they'll pull back. So it's actually given us the opportunity to expand our payer team to make sure we are communicating with those payers to provide the evidence necessary.
Nadia, how about you? What are you seeing as far as the posture of payers out there?
Yeah, I think Tracy said it really well with Medicare Advantage. We are definitely seeing a huge increase in that, especially just based off of the patient population for glaucoma patients. A lot of Medicare Advantage, some Medicare fee for service, and then probably a smaller group of commercial plans. With these new products that come to market, the FDA will approve a certain label or certain criteria that qualifies a patient, but these plans might set their own restrictions and are usually going to be more restrictive than less, trying to dictate patients to go to lower cost therapies that might have all the side effects that Matt mentioned, with irritation or non-compliance or any of the variety of reasons why drops maybe aren't the best solutions for patients. So really, navigating what those policies are, what those requirements are, is what companies like Alcon and Glaukos can help you guys with, is understanding and getting through those steps to get approval. I would say the good news is there usually is access to a lot of these IG interventions. It just may require some steps to get there, but those steps, a lot of patients seem to have met based off of their, previous therapies of drops or, whatever medication regimen they were on. So it's just all about navigating that and trying to, relay it to the payer in a way that they understand this is medically necessary, this is why this is the better option for the patient. But that is not seamless. Definitely, payers, especially some of the larger ones, will push back as much as possible, deny prior authorizations, even if patients meet the criteria. And I think the biggest thing there is just to keep pushing and appealing. And that's really where we have seen some like momentum and change with the plans once they see that demand in the market for these treatments.
Well, I think that, and you both kind of reiterated this, but the reluctance of the quick approval, that they'll maybe stand their ground as long as possible until there's an overwhelming body of evidence, is going to continue to be the case, and it really shifts responsibility back to us at the practice to figure out, okay, so how much do we believe in this? And then what do we do when things are denied? Because the practices that I go into at times just kind of go pause up. They get a request for more paperwork, more documentation, and they just take that as no. Right. And I think that some of these things almost happen in an automated fashion. I remember in my professional upbringing, one of my mentors said, never be told no by somebody who can't tell you yes. And if the MO of an organization is to just say no to begin with, then we got to get through that first set of no's. Um, Tell me what you encounter when you're talking to practices, or Nadia, when you're talking to, training the people who are going into the practices. What would you say is the state of the current practice right now and their ability to be confident in working those claims?
I can start. Sorry.
Yeah, go ahead.
Um, I think it really depends on the confidence level of where those practices are at. And I think it comes down to, is there a champion for IG in the practice? If there is, that person is usually really good of implementing a process in place from, when the patient's identified and that insurance verification is done, all the way to making sure that when it gets billed out, it's done correctly, that payment's coming through. So developing a champion is a great way of doing that if there's not one already in the practice to help. And groups that have gone through this before with other procedures, maybe they have done, have a really good process in place for other things that they're doing. Maybe they also do retina in the practice and very experienced with products like this. Those seem to be the ones that adapt quickly to this and are able to really make sure there's a process built out and that when they get a no, to push back as much as possible, and use the resources that are out there to help support with that.
Tracy, how about you? How do you think practices are current state, capability wise?
Right. I think there's a range, and Nadia, you explained it really well. When there's a champion in the office for the process, for when there's a denied claim, makes a huge difference. And I mentioned earlier, we see so much staff turnover. I can empathize and see where
Mm,
it's challenging for practices. However, a reminder that we're here to help. Nadia's team, my team, we're all here in this together for access for patients to get care, really. So I love these kinds of opportunities where you bring Nadia and I together and our
yeah.
message is the same as far as industry. We could have, we're from different companies, but we're all in this together to help glaucoma patients. That's what drives the work that we do on a reimbursement standpoint. So having that champion, having the process in place, because it will take extra work. And that sometimes can be the barrier to doing something different is that initially, and I stress initially on purpose, initially it will take more work to implement a new process. But once you have that process in place, we're here to assure everyone that it will make things easier down the road. And then when you get those patients back that say, thank you, I am so much happier that I had this procedure and that I had this treatment, it makes the world of difference, right? So it's what level of investment will a practice make on the front end to see that annuity and the benefits come back after.
Well, and I think this category, at least for me, the inflection point is that having grown up in the LASIK world, and then the cataract world, and then the cataract plus elective world, it feels kind of strange to me to be in this now exclusively reimbursable world. However, and this is, I think, a really important consideration because I'm a businessman first. My doctors aren't, but I am. And one, there's this kind of moral imperative that the doctors feel because they know there's patients out there who are progressing in their disease, who, and I mean, just deep down in their guts, they know they're not taking their meds. We all know. And we know how much of a drag that is on the practice. And meanwhile, there's these interventions that we're not sure exactly how to implement. But when we do, from a business standpoint, guys like me start to say, wow, this is actually as profitable, air quotes. It's as good of business as cataract surgery can be, especially if we look at the lifetime of that patient once they've been diagnosed with the disease, whether it's a laser and then a procedural pharmaceutical and then some kind of interventional MIGS procedure or combo. There, we it's among the more righteous things that we can do in our profession, and it's something that we can do for the health of our organization as well. Give me a sense, if you don't mind, and I'll start with you first, Tracy. Um, do you get a sense that glaucoma is a loss leader, or are practices finding that by paying attention to these patients and doing the right thing, it actually can be a nice profit center for them? Profits, by the way, I always got to be careful when I'm talking industry. Nobody says profits except me, but that it can at least be good for the clinic for the long term.
Right. Um, I think we still have work to do there, Matt. I don't think we're there yet. And I don't, I don't know. I think there's a place for, I feel very passionate about interventional glaucoma. So don't get me wrong when I say this. Drops are not going anywhere. There's so many patients on drops that if it's the same thing like with elective cataract surgery and advanced technology IOLs, right? There's still a lot of monofocals that are being put. The majority of patients are getting monofocals. So when we talk about where do I see this as a profit center, and like you said, you're the one that says that. I don't.
Yeah.
I don't know if we're there yet. I In some regards, it's just going to take a little bit of time, have discussions like this to see that it's not a money loser, which is good. It's helping patients. And when you utilize the resources from Glaukos and Alcon specifically, since we're the two companies represented here, we're here to support to make sure it's not a money loser. But it takes all of that work on the front end to make sure you're not losing money, right? And I think part of it goes back to, it goes beyond.
Oh, she froze up for just a second there. And so I might fill in the blanks for her just on this and send the conversation back to you, Nadia. But the question I want to clarify is because these are our existing patients and because we already know that they're diagnosed, but maybe we haven't intervened from a surgical standpoint. We can we now have an opportunity to go back to people and help them in such a way where maybe we wouldn't have before. We wouldn't have done an intervention, and drops do have a place. I think they have a good place after an intervention as kind of the bridge between surgical interventions. Can you respond to that a little bit?
Yeah, absolutely. So we have and I know Matt, you're very familiar, but a practice integration team who has done some really interesting data analysis and work in understanding patients that have just been on drops. And then, what that retention rate is. And I think some of the data that they found has been really surprising to physicians and to their practices and understanding that just by putting patients on drops, a lot of those patients aren't coming back to the practice. And I wish I had those exact numbers. But what we've seen is with that intervention, that those retention rates increase. And of course, between interventions, there's going to be that need for bridge therapy, or maybe patients don't completely come off of all of their drops. They still stay on like one or two. So there is still that place for
Mhm.
drops, but really from like a practice level, in addition to all of these procedures being covered, by Medicare and most other plans. So, reimbursable procedures, there's that higher retention rate as well, by intervening earlier with these patients.
Yeah, that's a really good point. And while it's not widely um, adopted quite yet, it is important that people understand that pathway. What we were just saying, Tracy, was you're right about the drops. They're going to have a necessary part of our program. However, at least for me, the drum I'm trying to beat um, is that drops are a good bridge therapy in
Mhm.
between interventions,
Yep.
right? That way we've at least stymied or halted the progression as much as possible, and now we're maintaining. But I do think you're right that there's an important component of the drug therapies that are part of the solution, and if the innovation is any indication, I think that there's going to continue to be innovation, new drug therapies out there. How they're administered, I think, is going to be another point of innovation. I want to just ask a question now because it's back to the practice. You both said that you think there's a range between the proficiency of a practice, and I know that you're very careful not to, you know, you probably don't want to say, anything tough about practices, but as an administrator, I feel like, man, we should be better at this. It's a really important part of our work is to make sure that the work that we feel like is the best for the patients and the work that the medical and clinical team is already doing, that we're doing the work on the back end to make sure it gets paid for. And I just think that as an industry, we can do better. It's been easy for us to take our eye off the ball. And maybe the reason I'm so staunch on the reimbursement and the profitability comment is because that's directly in the face of other categories where we're seeing declining reimbursement, which
Hmm.
frankly has been the major point of our focus the last 15 years. It is only there where
Right.
maybe I feel like maybe I got soft on working claims and knowing the basics of coding, reimbursement. When was the last time, Matt Jensen, you read a contract from a payer and have followed
Mhm.
up to make sure they're actually paying that way? How important are these, what should be basics, to overall practice health?
Uh, can I go first?
Yeah,
And sorry, I got cut off.
it's okay.
I jinxed myself saying I got on with no technical difficulties. Um, I don't know if you saw my eyes, Matt, when you started talking about contracts and I started lighting up a little bit
I
because
did.
you're 100% correct. It's so important. And Nadia, you most likely have experience with this too. Sometimes 66991, it's been out for years, may not be on a commercial contract, right? So my team will get calls, Nadia and her team will get calls. I didn't get paid. I'm not using this anymore. Well, it's let's look and identify why you didn't get paid. Sometimes it's because it's not part of the contract. So I've met with customers that really are very protective and believe that their contracts are so lucrative for them. If they poke the bear, they're going to be negatively impacted. And I'm here to say very confidently that is not always the case. Sometimes making an amendment to a contract is most profitable. If new codes aren't included on there, you're starting out way behind. You're not going to be in the not even you're not going to be in the neutral zone. You're going to
Yeah.
start out behind the money in the red before you even get started. So contract review is really important, and also understanding the payer mix for each market is completely different. I always use Troy, Michigan as a great example because Troy, Michigan is 83% Medicare Advantage. If providers in that market don't understand what that means to how they get paid, they will be at a disadvantage. So, yeah, it's really important. And I'm very passionate about that.
Yeah, and I can tell I love it that you are. I think I see an opportunity here for us to have um our joint partners like the ASOA and others have maybe even more training or more resources. Maybe, if there's a resource for contracting 101, I'd love to invite them onto this call. And the same thing is true, by the way, for things like just understanding buy and bill. By and large, practices have not understood that if they're anterior segment. Posterior segment, they've got it nailed. But they
Mm-hmm.
also, you know, at 30 million of revenue might carry 29.5 million in drug costs
Right.
also. So it is a real timing game that they need to understand and work through. Contracts and buy and bill, I think, are going to be something we talk a lot more about. Um, but I wanted to give you an opportunity to respond to that too, Nadia, about the importance of practices knowing and understanding their contracts.
Yeah. That is a big area Glaukos is focused on right now as well because of these payer contracts, especially for maybe these glaucoma specialists, haven't been set up in a way for these newer technologies coming onto the market, or procedural pharmaceuticals. So really there is that, pre-work or front-end work that would need to be done by either the practice or the surgery center to make sure that those contracts are favorable, ideally to before any patients get treated, just to prevent some, issues on the back end with payments or rates being too low. But, the more demand there is from a, provider standpoint, there is that potential for those contracts to be favorable, especially I forget if it was Matt or Tracy mentioned, new technologies, adding something into the contract there to kind of, carry that forward for the next technology that comes out. Because there's going to be more in the space and more options for these patients. So just getting ahead of it to really make it a worthwhile, you know, procedure for these groups. And, Medicare kind of sets the bar in terms of their reimbursement. They have their published fee schedules, and that is easily accessible, pretty standard across the board. But if Medicare Advantage or commercial, those can be a lot more favorable than Medicare fee for service too. So just knowing how to navigate that and having someone within the practice who's looking into the contract, or, you know, contracts are legal documents. So even hiring like a contracting consultant, I think AAO has some recommendations on consultants too. So that's another option that we talk about as well to help navigate these things.
Yeah, we should bring those folks forward. Just from my own experience, there's not a lot of them, and but we'd love to see more of them. I want to make sure that people have an opportunity to ask some questions. I know we've got a few people left. I'm wondering if something technical happened, Tracy, because five of you dropped about the same time, and
Oh,
so
okay. So it
um,
wasn't me.
I don't think it was you, but maybe,
But we don't know.
but we don't know. Does anybody have any questions for these two while we've got them on the line? I know we covered a lot of ground, and all we've done is kind of touch the top of the mountains on our way through. We haven't gone, deep on any of them. What I do want to talk about, however, is there is an answer to some of the questions we've put together with ASOA and Askers a course on this. It'll be the day before the Askers meeting starts, and it's jointly sponsored by ASOA and Askers. Both companies represented here today are affectionate towards the program by way of their sponsorship dollars, but it's called the Business of Interventional Glaucoma, and it is the deep dive on all of the things we just talked about. It goes to a deeper level on precisely how to use the codes, precisely the next step when you receive a denial, what you say on the phone call when you're calling the insurance to contest their denial, all of those things, and plus the macro view of the status of kind of where innovation exists. It's designed specifically for your providers, but also your team. So if you've got technicians, coders, schedulers, billing people, and they're coming to Askers, consider having them come a day early to come to this course. I think it's going to be really helpful for all involved. Last year's certainly was. There is limited seating, and we've already got a bunch of people registered, so keep that in mind. The other thing I'll just mention is I want to plug our session for next week. We're going to have our friend Dr. Brian Zabo from Newsom Eye in southern Florida. He's going to be talking about light adjustable lens and his usage in his practice. He's got a lot of volume there. Before we do, though, however, I've got a mentor and friend on the line. Kirk, I don't know if you can hear me. Maybe you're mowing your lawn at the same time. But pretty much everything I know about reimbursement I learned from Kirk. And I've committed to never learning more because I just call him instead. But you and I are doing a webinar just before Oscars on this topic as well, Kirk. Just share some wisdom with us on this topic before we say goodbye.
I do have to ask one question, Matt. Love you dearly, and I'm still trying to find out if you can spell ophthalmology.
I can't.
Okay, good. We're consistent. Good.
I can't.
I will say
I have people for that.
you mentioned the one thing that I share with physicians routinely, and they all sort of go, "Oh, that makes perfect sense." And you mentioned it, someone mentioned it earlier, is compliance and documenting that. Our surgeons, offices, clinics, staff do a wonderful job of documenting compliance issues when it's egregious. I haven't used my drops in 3 weeks, or I use it once a day and I should be using it twice a day. We don't document the patient that's like, I don't remember, I can't recall. And one of the things that I asked many docs is, how many of your patients are 100% compliant? And they all shake their heads and go and say zero. And I say, so if you addressed, hey, there's some possible compliance issues with this patient, is that inaccurate? And everyone says, no, it's not. And so that's just one piece of the documentation that I think payers are looking for. Why are you moving to that next step, that interventional step, whether it's from drops to SLT or SLT to something more interventional? So that's just one pearl from a clinical side that I think helps support when we have to do some appeals or denials or arguments, call it what you will.
Yeah, it should almost be your opening two slides of every talk, and I'll bet it is. That um, document. So
Sorry, Matt. It's
no,
an
it's
easy
right.
one. That's
It's
why.
right.
And they just don't think about it.
Better to be reminded than told, right? So keep reminding us. Listen, everybody, thank you for your time. I want to get everybody back to their days. Tracy, always good to have you. I hope to have you back and you as well, Nadia. It's been fun learning from you both, and I look forward to you continuing to help us open access to these important technologies. It's going to help a lot of people.
Yep. Thanks so much for having us. Great to see everybody.
Good to see
Yeah,
you again.
thank you so much.